We know that 1 in 2 women over the age of 50 will sustain an osteoporosis-related fracture in her lifetime. In this session, we're going to review a couple topics. The first being, how well do you know your bone health? Second, what are the risk factors for bone loss and what that threaten our bone health? Third, we're going to talk about how we can diagnose our bone health with confidence. Fourth, what's the recipe to keeping your bones healthy and strong? And fifth, we're going to wrap up with the bone health checklist to make sure that we're feeling strong and empowered at the end of the session. Consequences of osteoporosis-related fractures are often underdiagnosed and underappreciated. Things like wrist fractures, hip fractures, forearm fractures, pelvis fractures, vertebral fractures, these create many changes in women's life. They create pain, height loss, mobility, changes in physical functioning, loss of independence, and even contribute to morbidity or mortality. So it's really important that we think of bone health as a silent condition. We know that the consequences of osteoporosis are not silent and contribute to significant changes in our women's lifetime as well as our health span. In the Power of Bone Health Strategies for Every Stage of Life, we'll talk about how we can equip ourselves with evidence-based information on how to prevent, treat, osteoporosis. We know that so much of osteoporosis can be prevented. We can do so much before menopause, at the time of menopause, and thereafter to prevent falls and fractures. So educating ourselves, we think, is very powerful. Education awareness brings understanding and how we can prevent and treat this very important and underdiagnosed condition. My name is Dr. Kristi DeSapri. I'm a board-certified internist here in the United States. I started my career in OBGYN. I loved taking care of women in the post-reproductive years and felt that's where my passion and where I could really serve women the most. I completed a fellowship at the Cleveland Clinic in women's health. I practiced in both private practice here in the United States as well as an academic medical practice at Northwestern Medicine in Chicago. I was the director of the Northwestern Women's Bone Health Program at the Center for Sexual Menopause in Medicine, which is all to say that I really have spent the majority of my career just seeing women for the consultative roles and menopause, perimenopause management, sexual health, osteoporosis, bone health, and that's what we're going to be speaking about here today. So we're going to start our masterclass with how well do you know your bone health? Dial back to thinking about bone mass as we grow. In our teens, our 20s, we build our bone mass. I liken this to something called a bone bank and how I describe that to patients. So we build our bone bank through our teens, our 20s. That's both our cortical bone, which is the long bones in our body. So the long flat bones of the femur or the hip, as well as forearm. And then trabecular bone, which is bone, or we call that cancellous or spongy bone, which is bone that's just in the inside of our bones and predominantly in our spine. So we build these bones for our teens, our 20s, and then generally in our 20s, we have the most amount of bone that we're going to build. And women have less bone density because we have smaller bones. We don't have testosterone that makes the bones as large as men. So when I see women, I really want to talk about, again, looking at midlife, what are the changes at bone health that we need to predict? And then how do we need to prevent and then treat? So menopause, regardless of when that occurs, whether that's natural menopause at age 51 and a half, which is what's thought in the United States is a normal menopause, a typical menopause, I should say, or surgical menopause earlier, anytime we have menopause, we know that there is a loss of estrogen or estradiol from the ovaries. And bones are very specific to estrogen and have estrogen receptors, both alpha and beta, on the bone cells and every bone cell in the body. So when we lose estrogen, what happens is there is an imbalance of bone that was being formed and nicely being formed before menopause. There's an imbalance and more bone becomes lost. And we have cells called the osteoclast, which are the bone breakdown cells. And with less estrogen, those osteoclasts go in overdrive. So the way I describe it to patients is this looks like a teeter-totter or a balance. So in premenopause, we're building bone, breaking down bone. And then when we start to lose estrogen, those osteoclasts, and that's generally due to rank ligand, which is an inflammatory marker, starts to increase and that imbalance shifts. And so less of our bone is formed. And so when we think about bone like a nice lattice structure, it starts to thin. And that again is the start of bone thinning or osteopenia or osteoporosis. We're going to move on to risk factors that threaten our bone health. Certain factors influence peak bone mass. When we think about bone loss, we have to first think about how we can, have peak bone mass. That can vary widely. 70% of our bone mass is inherited, which means reasons we ask about family history of osteoporosis or fractures is because this can be genetic. So if our mother had a hip fracture primarily before age 80, that's a very strong risk factor for osteoporosis. A lot of times we weren't asking women about these questions. And so I come about them asking a different way. Did your mom lose height? Did she break a bone? Because oftentimes if you say, did you have osteoporosis? The answer is going to be no. But did she break a bone? Did she lose height? How early did she pass away? We know that hip fractures, and this is something we'll discuss, hip fractures carry a significant morbidity and mortality with them. So it's very important to know your family history and your genetics. Time at menopause is critically important for how much bone mass we have, because we start to lose whenever we have menopause. So it's surgical early menopause. Again, early menopause is menopause before age 45, or premature ovarian insufficiency, or menopause before 40. That has dramatically decreased your bone mineral density, increases your risk for fractures, cognitive decline, dementia, a lot of cardiovascular disease. So this is just as important to ask about bone health. Lifestyle. So if you were doing any smoking, what your nutritional level was when you were a child. Did you drink milk or calcium-rich foods? Did you grow up doing any exercise? All of these things really make it important, because that's when our bones are being strong and being built. Certain medical conditions. So certainly not everyone that I see is healthy, and there are a lot of medical conditions that we have no control over. So things like rheumatologic conditions like rheumatoid arthritis, autoimmune conditions like lupus, stomach conditions like inflammatory bowel disease like celiac, Crohn's disease, ulcerative colitis. All of these, again, affect either calcium metabolism, vitamin D metabolism, or fracture risk or inflammatory markers. So women with those conditions, we know that gastric bypass surgery also affects malabsorption. So those surgeries can affect how we metabolize calcium, and then thus impact our bone health. So again, when we think about bones, we need to be thinking about calcium, vitamin D, bone strength, and any condition that can affect that. When we think about medications, so many medications also can affect bone, and these are often underappreciated. So things like long-term steroid exposure, or things like, we have so many patients, I have so many women with breast cancer who have been placed on hormonal therapy, such as aromatase inhibitors. These all, again, drive estrogen down very low and then affect the bone. And oftentimes these are given to women at the same time of menopause, in their 50s and 60s, because we know that we are diagnosing estrogen receptor positive breast cancer in these years. And we know that then we are now giving anti-estrogens to impact breast cancer survival rates, et cetera. But these dramatically influence the bone. And we know that from large scale data that show that these women who are on aromatase inhibitors both have lower bone densities and higher risk for fractures. Other medications that we don't often think about are things like proton pump inhibitors, PPIs, SSRIs. These can all actually influence bone health as well, because of how they influence the bone cells, as well as estrogen and calcium, vitamin D metabolism.